Hello, I am Dr. Kozai, PhD from the University of Pittsburgh. I am a scientist and an associate professor of the Department of Bioengineering. Now, there was a lot of confusion and questions that started with, well, I'm not a scientist, we're not scientists. And so I was hoping that with this video, I'd be able to provide some insight into a number of the questions that were asked during the meeting. So the topics I would like to cover to try and answer some of those questions that were brought up is, let's first talk about the virus, right? And then let's talk about this Delta variant and how the spread pattern is very different. And then let's talk about how that has changed the definition of close contact from the health department. And then briefly cover some of the problems with masks. Then on to the CDC guidelines and legal considerations for some of these mandates. So SARS-CoV-2, the virus that causes COVID-19, is quite different from some of the other coronaviruses that we've seen in recent times. Just SARS-CoV-1, and the MERS virus. So SARS infects the lungs, tongue, kidney, heart, and liver, whereas MERS directly attacks the respiratory system. And that's why it has a 1/3 mortality rate. SARS-CoV-2 is different in that it infects all blood vessels, specifically pericytes. And just to show you how ubiquitous this cell is and how it's just sort of everywhere, this is 1/16 of an image. This is data taken from my lab. The red cells here are pericytes, and the green are labeling blood vessels. So you can see that they're quite, in fact, all over the place and quite densely packed. Now, these blood vessels are the body's power grid system and sewage system, right? So it delivers powers to all of the cells, energy to all of the cells in your body, and it removes all of the waste products. So they're quite important, and they're everywhere. So SARS and MERS, again, infect sort of the respiratory system. And so if you have a very healthy, well-trained respiratory system, you can compensate for large amounts of damages that could occur to your respiratory system. So how COVID-19 is different is that the SARS-CoV-2 virus can infect anywhere in the body, anywhere there's a blood vessel, which is virtually everywhere. And of course, right, the virus comes into the body through the mouth and the nose. Now, the virus can land again anywhere in the body that has a blood vessel, for example, sort of randomly a leg, right? And if that happens, you're probably okay. If the virus lands first in the leg and then spreads to other parts of the body, your immune system has a time to ramp up and produce antibodies before the infections on your key systems become unmanageable. So you're probably okay. The problem is that when viruses infect critical systems like the respiratory or immune organs, this can lead to hospitalization and death just because the virus ramps up very quickly. Now, this is especially true if the virus lands inside the brain. Best case scenarios, this can cause long COVID. We'll talk about that in a little bit. And the worst case scenario can lead to death. So where the virus ends up landing is somewhat of a random luck. It has nothing to do with age. It has nothing to do with fitness level. And if it lands in the brain, it's going to cause a lot of problems. And of course, the virus comes in through the nose and the mouth, which is proximity-wise very close to the brain. So if you are one of these unlucky individuals where the virus infected the brain, some of the symptoms that you'll see are loss of taste, loss of smell, brain fog or cognitive and attention deficits, new onset anxiety, depression, psychosis, seizures, suicidal behaviors, accelerated Alzheimer's progression, brain scarring and Lewy body formation, accelerated brain aging, and brain degeneration. Now, separately, these symptoms are kind of all over the place, except there's a couple of conditions where this is actually all of these conditions, all of these symptoms appear, and that's stroke and traumatic brain injuries. So vascular injuries in the brain can lead to all of these things. Now, the degree to which you have these effects will vary depending on if the virus infected other parts of your body first before migrating to the brain, and how much time your immune system had to ramp up antibodies before the virus migrated to the brain. So why is this important? The blood-brain barrier is an important part of the body that separates the brain from everywhere else in the body. So if you take, this is old work from 1920s, if you inject a vascular dye, Evans blue, you'll see it leak to everywhere in the body except for the brain and the spinal cord, because it's separated from the rest of the body through something called the blood-brain barrier. And inside the blood-brain barrier, it's separated like this because there's a lesser immune system inside the brain. I mean, there's a number of reasons for this, but the reality is that's what it is. And those blood vessels also still have to deliver oxygen and nutrients into the brain and remove waste products from the cells, from the neurons in the brain. And so there's, again, a lot of blood vessels inside this brain. And the blood-brain barrier also permeates through this blood vessel. And pericytes are an important component of this blood-brain barrier, of these blood vessels. They're the things that keep the blood vessel from being leaky. Now, COVID-19, or SARS-CoV-2, the virus that causes COVID-19, infects pericytes, specifically through the ACE2 receptor. So we know which receptor it is. And the function of that is not important. The important part is that it does infect pericytes. Now again, these are the cells that keep the blood vessels working and tightly sealed in the brain. Without pericytes, you start getting vascular regression. The blood vessels start degenerating, becoming leaky, which means that oxygen doesn't transfuse through them efficiently, and waste products aren't able to be cleared out. And this leads to neuronal damages. The neurons literally start dying in the brain, which has led to a number of studies. This is just one of a dozen. Here they're showing cognitive deficits in people who have recovered from COVID-19. Without going through the entire study, I just want to point out one sentence that is really resonating is people who have recovered from COVID-19, including those no longer reporting symptoms, exhibit significant cognitive deficits. Right? And so these are the things that scientists are now looking at in terms of long-term effects. Because the virus has been around for a year and a half, we can start looking at this. But again, the virus has only been around for a year and a half. There's a lot more that we need to learn and understand. Now, 50 years ago, we thought the brain was not able to heal. The neurons that you have in your brain right now is the most that you'll ever have. It turns out that that's not necessarily true. What we've learned now is that there's about 100 to 300,000 backup neurons programmed in your brain. But once you exhaust those backup neurons, you start getting permanent cognitive decline or dementia and brain degeneration. And if you remember here, the COVID-19 virus infects pericytes. Pericytes are key cells that make up some of these backup neurons, right? So the infection causes a much more rapid decline in your backup reserves. This can lead to accelerated brain aging and cognitive decline, as shown in the previous study. Why is this alarming? What do we not know still? Well, when will we start seeing problems in infected children as they age? How will we identify problems in adults who were infected as children? And how will things like concussions from sports or car accident accelerate brain aging, cognitive decline, dementia, etc., in adults who were infected with COVID-19 as children? We have no idea. We just don't have enough data points. Now, before I move on, I want to sort of briefly talk about the adaptive immune response, and without getting into the politics of it, just briefly talk about vaccinations. So you have an exposure to a virus. This is just general, has nothing to do with COVID-19. But as an example, I've listed here the alpha variant in red. So you're exposed to some virus. You'll see an increase in virus load, virus production in the body, until some point that your body starts producing antibodies. And as the antibody production ramps up, the body begins to start clearing out the virus until you heal. If your antibody production is slowed or doesn't reach this height, the virus can continue replicating and eventually you will reach a terminal point. Now, if you're vaccinated, essentially these cells have an ability to ramp up much faster, right, and can reduce the production of, or reduce the virus load. And with the alpha variant, that's exactly what we see. We see a much lower virus load in inoculated subjects. Right? And what this means is that the virus never reaches a point where it can be transmitted easily in vaccinated people. The reason the Delta variant changes the game is because it ramps up so fast that even in vaccinated individuals, the antibody production delay is still quite substantial, leading to a massive amount of virus load buildup in the body. Right? And it essentially leaves or passes the threshold for spreading viruses. So to understand sort of the health department's rules, we have to first kind of understand how the Delta variant has changed the game. We had the alpha, we had the beta, and now we have the delta. Transmissibility is how easily the virus can be transmitted, right? And we see that the Delta variant has 4 pluses now instead of 1 to 3 as previous variants. It also has quite an ability to evade the immune system, which is why you get to that virus load, that very high virus load of spreading the virus, even if you're vaccinated. So one thing that scientists have studied is the amount of virus in the nasopharynx of an infected individual. So the nasopharynx is this region right behind the tongue, which means that anytime you breathe in and out of your mouth or your nose, air has to flow through this. This is where the virus becomes airborne and spreads. Now, in an unvaccinated individual, the virus load in this region is very high. And so anytime you breathe, you're very likely to transmit the virus. Now, if you are vaccinated with the and you get infected with the alpha variant, your antibody production is able to suppress the virus from reaching very high loads in this nasopharynx area, which means that these individuals are not very good at transmitting the virus. And this is true with beta or any of the other variants. At least it was until Delta came along. And so Delta, because the virus production is so high, so fast, that even if you're vaccinated, you are able to spread the virus. The virus load in the nasopharynx is as high as an unvaccinated individual. Right? So the current working hypothesis is that, again, the Delta variant replicates much faster than alpha, beta, gamma, eta, iota, or any of the other variants. And so even with a primed or vaccinated immune system, the virus load still reaches a point where it can very easily and very efficiently transmit the virus. Now, vaccination still allows you to ramp up the antibodies before you reach a severe disease state, and so it is effective in protecting the vaccinated individual. So how this changes the game is that children under 12 are unable to get the vaccine. There's no personal choice here. There's no option here, right? And for the longest time, we've been operating under the assumption that COVID doesn't affect children. And that has mostly probably been true for the alpha, beta, and gamma variants, unless you have some underlying condition. The Delta variant has changed this completely. And again, the Delta variant has only been in the US for a month to a month and a half. So all of this is just brand new data that epidemiologists haven't been able to get all of their algorithms around. Right, so for example, children make up more than 2,000 of the new COVID-19 cases reported in Louisiana. This is August 2nd. I am as worried about our children today as I've ever been. This virus, the Delta variant of the COVID, is every infectious disease specialist and epidemiologist's worst nightmare. Some people thought kids could not get the virus or get sick enough from it requiring hospitalization. Dr. Leron Finger is the chief quality officer at Children's Hospital in New Orleans. I think they're wrong. I think that in the first 15 months of this disease, kids were certainly hospitalized at rates much lower than in adult populations. But over the last month, we've seen many, many more children admitted to our hospital and pediatric hospitals across the country. There were people who said children don't get the disease, they can't transmit the disease. We knew that those were fallacies all along, but particularly now that the Delta variant has emerged, it has become very clear that children are being heavily impacted by this organism and by this pandemic at this point, perhaps more than ever. And if you remember in our previous waves, children were really were spared. For the vast majority, either they didn't have symptoms or they had very mild symptoms. We had a few rare cases of kids being affected, then of some long-term complications, but nothing like we're seeing now with our children's hospital. Went from 0 cases to 20 cases in about a week and a half. August 5th, the American Academy of Pediatrics confirmed nationwide about 72,000 children and teens contracted COVID-19 last week, compared to 39,000 the week before. This is an 84% increase. We're seeing many more individuals of all ages, children, that we haven't seen before, probably because they had minimal symptoms. Now they have symptoms and their parents are aware of it. Physicians are aware of it, said Dr. Bob Lutz, the Washington State Department of Health COVID-19 medical advisor. COVID-19 and kids. Pediatricians in Palm Beach County seeing an alarming rise in children being hospitalized from COVID-19. In his practice of 7 pediatricians, Shishman said, "We have had a sick 3-week-old and then a 4-month-old. This is not sparing anybody. We've had teenagers in the ICU on a ventilator. We had otherwise healthy 5-year-old with a whiteout lung, a classic COVID chest x-ray." Florida logged 10,785 new COVID infections among children under 12 between July 24th and 30th, or an average of 1,540 new cases each day. That's 54% more than a week before and more than 600% increase over the same time a month earlier. Houston pediatrician warns parents to take COVID very seriously with children's hospitals full. We've had a huge surge in hospitalizations of babies and toddlers, in particular with RSV infections, RSV pneumonia, with respiratory distress and respiratory failure, requiring intensive care stays. And now we are also starting to see an uptick, absolutely an uptick, in COVID-19 infections in children. In the past 2 months, I have hospitalized more babies, particularly babies under 3 years of age, than I had in the prior 3 years. I don't want to yell fire in a crowded theater, but I smell smoke. This is a tremendous problem. This is not January, this is July. This should not be happening now. There should not be this many kids sick right now. Long COVID cases among children and pediatric death toll rises globally, July 26th. According to the organization Long COVID Kids, over 40 children today in the UK are being hospitalized with COVID-19 as the Delta variant has come to dominate. There's been a huge surge in the number of children becoming infected. New data shows a growing number of children who have tested positive for the disease have gone on to develop long COVID, with symptoms lasting beyond 12 weeks. So far in the UK alone, 33,000 children ages 2 through 16 and 71,000 young people ages 17 to 24 are suffering from long COVID. Right? And so this is the brain fog, loss of cognition, or cognitive decline, loss of IQ. Dr. Deepti Gridasani, an epidemiologist and senior lecturer for Queen Mary University of London, recently wrote an article on Long COVID Kids site pointing to 2 studies, the Office for National Statistics data study and the REACT-1 data study for the evidence of long COVID in children and young adults. He states that anywhere between 10% and 50% of those infected with coronavirus suffer from long COVID symptoms. Gridasani noted that for many children, their symptoms are not mild, but affect their lives in profound ways. Many of the children have not been able to return to some of their favorite activities. COVID surge drives South Carolina Pediatrics ICU to capacity, August 2nd. All of these factors have created a perfect storm that has strained capacity at Prisma Health Children's Hospital in Columbia, as more children are diagnosed with COVID-19 and other respiratory illnesses. The Food and Drug Administration must work aggressively towards authorizing a COVID-19 vaccine for children under the ages of 12, the head of the American Academy of Pediatrics wrote in a letter to Janet Woodcock. The urgent plea comes as the U.S. experienced a large week-over-week percentage increase in pediatric COVID cases since the start of the pandemic. Dr. Lee Savio-Beers, the Academy's president, wrote in a letter Thursday. Pediatric cases of COVID-19 have soared in recent weeks, in part because of the highly contagious Delta variant. 38,654 pediatric COVID cases were reported during the week of July 22nd. Within a week, on July 29th, that number jumped 85% to 71,726. Yes, children can be affected by COVID-19. Here's why doctors say they need to be protected. August 7th. Doctors say it's crucial to protect children against the Delta variant, not just to preserve in-person learning and protect their own health, but to help prevent even more aggressive variants from emerging. The Delta variant is as contagious as chickenpox, the CDC says. In just 2 months, the Delta variant jumped from 3% to more than 93% of sequenced coronavirus samples in the US, according to the agency. And with a rise in pediatric COVID-19 hospitalizations, it's not just children with pre-existing conditions getting hospitalized. Almost half, 46.4% of children hospitalized with COVID-19 between March 2020 and June 2021 have no known underlying conditions, according to CDC data from 100 US counties. Now again, the Delta variant arrived in June, so this is all data without the Delta variant. One Florida pediatrician mom shares desperate plea on COVID-19 in kids, August 7th. This is a tough time to be a pediatrician and mom. Delta changed everything. It's wreaking havoc on healthcare systems. This is the worst the pandemic has ever been, and children's hospitals are seeing numbers of COVID that we've never seen. I think, unfortunately, this is a precursor in some sense for the fall, Koh told Today parents, underscoring the Delta variant's highly transmissible nature. It's really quite surprising. You have a pathogen that's doubled its transmissibility within a year and a half of being discovered. And so this begins to shape the discussion on close contact. Now here's a German group that has shown through their imaging technique how much a virus can spread through normal activities. Now this is coughing, and then coughing on the left without the mask, and coughing on the right with the mask. And you can see just the amount of airflow is very dramatically different. And we're talking about 6 feet versus 3 to 6 inches. And now here we're looking at someone singing, and you can again see the amount of airflow being projected out of the person without a mask is quite dramatic compared to the same amount of singing on the right with a mask. You see that the airflow is kept in within the personal space of the person. Now we're looking at sighing and talking, and again you can see just how much the air is being projected out of the person without a mask on the left, and how little airflow is being projected away from the person on the right with a mask. So what this means is that if the person who's infected is not wearing a mask, the other people around them are not very well protected, even if they are wearing a mask. And the only way to really protect other individuals is if the infected person is wearing masks, which is sort of the bottom two examples. Before I get back to what that means, let's just talk about mask restricting breathing. Now, there's many different types of masks, and for the purpose of this conversation, I'm just going to introduce 3 and then just focus on one. So the 3 that I'm going to just briefly introduce are cloth reusable or surgical mask disposable. Okay? And there's the N95 mask, which filters are not reusable. And we have biochemical masks or gas masks, right? And their filters are also not reusable. Now, cloth and surgical masks do not filter virus particles. The meshes are too wide for it to prevent the virus particles from entering the person wearing it. But that also means that it does not restrict breathing. It does reduce the spread of the virus because it reduces the airflow from reaching 6 feet. It's also inexpensive, but it does not filter chemical agents. N95 masks, on the other hand, do filter virus particles, They do not reduce blood oxygen. They slightly increase respiratory load. It means that your lung has to work a little bit harder to pump air in and out, but it's not enough that most people are able to keep normal oxygen levels. This does reduce the spread of virus, but it's a lot more expensive, and it also does not filter chemical agents. In contrast, biochemical masks or gas masks, they do filter virus particles, but they also are designed to filter chemical agents, biochemical warfare agents. So the filters are much, much smaller. The holes on it are much, much smaller. And that does greatly increase respiratory load. But it also does effectively reduce spread of virus to zero. It's also very expensive, and many of these are highly regulated. And you will end up on a government watch list if you start collecting these. Now, for the rest of this talk, when I say masks, I mean cloth and surgical masks. Right? These are very effective and inexpensive. And there's dozens now, hundreds actually, of studies showing that face masks do not lower oxygen levels. So you can go onto WebMD and find dozens of articles cited in this. Wearing a cloth and disposable surgical masks have no effect on vigorous exercise performance in healthy individuals. This is from a recent clinical trial. There is no risk of hypoxia, which is lower oxygen levels. Carbon dioxide will freely diffuse through your mask as you breathe. Mayo Clinic, again, citing multiple studies, including many of their own. Face masks have no impact on oxygen level. The effects of wearing a face mask are minimal, statistically non-significant at most, even in people with severe lung impairments. Right? So they had people with severe lung impairments wear these masks and actually showed that their breathing slightly improved, non-significantly. So cloths and surgical masks are actually centuries-old technology that our ancestors have used while doing cognitive and physically demanding tasks without running out of oxygen. Scientists use these during surgeries and experiments up to 24 hours. Brain surgeons double up with N95 masks and surgical masks up to 8 hours at a time, doing highly technical and cognitively demanding tasks. Trauma surgeons and medical residents wear these masks up to 72 hours at a time. This is slowly starting to change. They're trying to reduce that to 16 hours, but in past, residents have had to be operating for up to 72 hours. Backcountry avalanche skiers doing highly physically demanding tasks where small mistakes can cost them their lives. Bomb disposal technicians, special ops, military forces, criminals. So I want to try and explain this from the health department's perspective, not my personal opinion. Masks work if the contagious individuals are wearing masks. Without masks, the close contact distance is 6 feet. With masks, the close contact distance is your personal space, essentially like 3 to 6 inches. If all infected individuals, non-symptomatic, were wearing a mask, you do not need to quarantine the classroom. By the time the first person becomes symptomatic, a non-masked person could have substantially spread the virus. This is why the entire classroom would be quarantined if there is no mask mandate. Okay, so with the Alpha variant, after you're infected, you don't start spreading the virus until about 4 to 6 days. And then symptoms begin to show up 8 to 10 days. In contrast with the Delta variant, and this is again data that's still coming in, so this can be revised, but the data seems to suggest that you can start spreading the virus on day 2 of the infection. And symptoms can start as early as 6 days. Now, I also want to address another comment, which is vaccines and masks are the same, in that they're both about personal choice, which is kind of true, but not. Vaccines protect the wearer or the person who received the vaccine. With the Delta variant, vaccinated individuals still spread viruses, which means that vaccinated staff who have been vaccinated do not protect 5 to 11-year-olds. Masks, on the other hand, protect everyone other than the wearer, which means that 5 to 11-year-olds are only protected if all students, staff, and visitors are masked. Why universal masking indoors? Dr. Finger says daycare centers should have frank discussions with parents. I think those establishments need to have a really sort of transparent conversation with all of the families that do seek them out as a daycare. And they need to understand that they're all caring for kids as a collective and that their behavior outside of the daycare have the potential to have major ramifications, meaning they need to practice safe behaviors. We do believe that you can have safe return to school as long as you adhere to that universal masking indoors is adhered to. What we learned last year is that when everybody was wearing masks as were mandated, the rate of transmission of the virus in the school was incredibly low. So one thing that was mentioned in the meeting was that we're exactly where we were a year ago and nothing has changed, and we need to change something. Now I want to provide some perspective to that. August 2020, there was no FDA-approved vaccine. Clinical trials had started in March, but the FDA emergency use authorization didn't come until December 2020. Now we are in August 2021. There is a vaccine approved, albeit through the emergency use authorization for 12 and over. But there is no vaccine for 11 and under. Clinical trials for 11 and under have started in June, and experts seem to anticipate that the vaccine will be available somewhere between December and March. And according to history, this is when we start returning to normal, when we can start getting rid of the masks, but not before, if you want to avoid a school shutdown. Another thing that was mentioned multiple times is that this was a never-before public health crisis. But it turns out, actually, if you go back to the history books, America has experienced similar school shutdowns from viruses, smallpox, polio, Spanish flu, measles, etc. And we have come back to normal from these when vaccinations were available to all. And so let me just show you this chart. You can see that many of these more transmissible viruses have led to school shutdowns. Smallpox and polio actually are the only ones that don't have a current state mandate, only because we've been able to eradicate them. In the past, there was a state mandate for polio and smallpox vaccines. Now, one concern that I heard that I think really should be addressed is that special needs children need to see faces to read emotions or read lips, right, for hard of hearing students. And there are solutions for these, open window face masks and face shields. Right? And I think the school district really needs to identify these children and make these options available for the students in the classroom and the teachers. Now, current CDC guidelines is to actually mandate universal indoor masking for all teachers, staff, students, and visitors to K through 12 students, regardless of vaccination status. And this was updated August 4th after the superintendent's health and safety plan was proposed. Now, this removes the individual option and turns it into a mandate of universal indoor masking. When Dr. Mannarino unveiled his health and safety plans, the guidelines were different. This is July 27th. At the time, CDC was strongly recommending all individuals, including fully vaccinated individuals, to wear masks in K through 12 schools, leaving the option to individuals. But this has changed because we're seeing more data from the Delta variant. Now, the consequences for infection is the quarantine guidelines. If you're in close contact, right, which is 6 feet without masks, which means everybody in the classroom, because as Dr. Mannarino said, the maximum distance that they can get in a classroom is 3 feet. That's 14 days of quarantine without testing, or 10 days of quarantine with a negative PCR test on day 8. If you test positively, you have to show 24 hours continuous without fever, without a fever-reducing medicine, right, after those 14 days. Right, so North Hill School District does actually, in fact, have a dress and grooming rule, right, or set of rules. Shoes, shirts with pants or skirt, and hygienic grooming is mandated by North Hills School District. Claiming a personal choice of being a nudist does not exempt individuals from the dress code for health and safety reasons. Cloth masks can be part of the dress code as it relates to health and safety and hygienics. And this is in fact the route that thousands of school districts have gone throughout the U.S. There's a legal argument here too. Supreme Court ruling of Jacobson versus Massachusetts. Massachusetts mandated vaccines, and Jacobson claimed that it violated the 14th Amendment, depriving any persons of life, liberty, or property without due process of law. In a 7-2 vote, the Supreme Court acknowledged the fundamental importance of personal freedom, but also recognized the rights of individuals in respect of its liberty may at times, under the pressure of great dangers, be subjected to such restraint to be enforced by reasonable regulations, as the safety of the general public may demand. Meaning they ruled in favor of Massachusetts over Jacobson. And this also introduced the reasonableness test. Is the requirements here reasonable? Is the public demand, public health and safety demand reasonable to infringe on one person's liberty? And American Academy of Pediatrics and the CDC provide cover for that reasonableness test. Not only did the Supreme Court uphold Jacobson, rule in favor of Massachusetts and Jacobson versus Massachusetts, they also reaffirmed Jacobson in Massachusetts in Zilch versus King, setting precedent on precedent. And so Jacobson versus Massachusetts has actually been used successfully to enforce mask mandates throughout the U.S. Now, there are limitations to Jacobson versus Massachusetts, and one of the biggest ones in the Supreme Court was the Roman Catholic Diocese of Brooklyn versus Cuomo. In a 5-4 vote, they decided that it was not fair to have two sets of rules for two groups. This is discrimination. Cuomo had set up two rules in terms of number of people that can be in a business, or in a number of people that can congregate between business and religious institutions. So now this leaves several legal questions that are open. Can you have two sets of rules for ages? Right? For a 2 through 11-year-old whose vaccinations are not available, and 12 and up where vaccination is an option. Right? Which is, I think, why the CDC recommendations have now been updated to universal indoor masking for all teachers, staff, students, and visitors to K through 12 schools, regardless of vaccination statuses. Another open question is, can states mandate an emergency use authorized vaccine? Because full approval vaccines take a lot of time, rigor, and massive amounts of data to prevent bad vaccines from hitting the market, which has happened in the distant past, and which is why the rules are so rigorous to get full approval. Now, COVID vaccines do not have full FDA approval, only emergency use authorization approvals. And legal experts seem to agree that states will likely mandate once full approval, FDA approval is made using the Jacobson versus Massachusetts. And I also want to provide an example case for this age separation. If a high school student who is vaccinated, where masks are optional, becomes infected by someone not wearing a mask, even though they have a sibling who's going to the elementary school, which does require masks, the infected high school student can come home and infect the younger sibling. Now, the high school student has a vaccine option, so will likely avoid severe illness. But with the Delta variant, where we know the immune system evasion is much higher, the transmissibility is much higher, and the ability to replicate is much more aggressive, this younger sibling is not protected from severe illness and does not have the option to be protected from severe illnesses. So to summarize, Delta variant replicates so fast that vaccinated individuals can spread the virus at the same level as unvaccinated individuals. Delta variant is causing severe illnesses, cognitive deficits, and hospitalizations in children, which is unlike the Alpha variant. Masks are only effective if infected individuals are wearing them during their pre-symptomatic phase. This explains why the health department requires quarantining entire classrooms that do not have a universal mask mandate for all students, teachers, staff, and visitors. This would mean more students will likely miss more schools. Cloth and surgical masks do not impact oxygen levels or respiratory or cognitive ability, even during high intense activity. History has shown that we will come out of this, through smallpox, polio, etc., when vaccinations become available to all ages. Masks are articles of clothing, as in dress and grooming rules. Jacobson versus Massachusetts provides legal cover for mask mandates. AAP and CDC guidelines provide reasonableness tests. AAP and CDC guidelines is to mandate universal indoor masking for all teachers, staff, and students, and visitors to K through 12 schools, regardless of vaccination status. So, just to conclude, AAP and CDC cannot make rules. Federal, state, local boards, business owners can make rules. CDC can only recommend rules, because Congress never gave the CDC the power to make rules. These are children's lives. Any child sick is a child sick. I don't want to see any more children or any more kids ill because of our mistakes as adults. Now, I appreciate the difficult decision ahead for this board, but I hope that this information is useful in making an informed decision. Thank you.